conference so far. Let me talk.
We have enough time for the question.
Okay. Good morning, everybody, and thank you for joining us this morning. We're here in the pediatric room for the abstract session. We have a few announcements to start. Again, thank you to AMSEC for this wonderful meeting. Please don't forget to scan the QR code to get your CEUs. That will be located at registration at the front desk. Additionally, there are QR codes in the back of this room for the new pediatric standards and guidelines updates. Please make sure to scan that and check out what we've been working really hard on. We have a blood drive going on. Our goal is to save 100 lives. If you haven't registered and you're interested, please consider donating. And lastly, we have a social on Saturday night, and we need all of you there. Jazz band, good drinks, great company. So today right now we'll start our pediatric abstract session. Our first speaker is Amber Palmer. She is a pediatric perfusionist at the University of Pittsburgh Medical Center Children's Hospital. And just press that in.
Hi, everyone. Good morning. It's early, but hopefully I can grasp your attention for a couple minutes. So today we are just going to talk about UPMC's Children's Hospital experience using microblenders to help regulate lower sweep gas rates. So a few of the goals, they're just quick to review. We're going to be talking about the problem, which is sweep gas regulation, how we address this problem at Children's, and how then we implemented it into ECMO and then later on to bypass. Slide. Yes. There it goes. There we go. Okay. All right, we're back. Short intermission. So again, we're just going to be talking about the goals and how we implemented sweep gas regulation into bypass and ECMO. So our problem, it's just regulating PCO2 can be very difficult in the pediatric population just because we're dealing with such low sweep gases, especially with the neonates. And we say that there's two different solutions. One, you can either blend in CO2 or to use microblenders. And bleeding in CO2 is an option, but it's more difficult and more complicated. We work hard to make our circuit pretty simple, and adding in CO2 to an ECMO circuit would just make it more complicated. So we then move to microblender, so either ball regulator versus dial regulator. So we started off with the we started off with the ball regulator because it was easily accessible. We just went up to respiratory, we asked for them, we got them, and we put them on our circuit. The pros of them is that it's cost effective and it's easy to get. But there were a lot of cons because it's inconsistent. It's kind of hard to see because what I think maybe is 0.35 would be somebody else's 0.45. So there was a little bit more inconsistencies with it and overall just inaccurate. So we ultimately then decided to move to dial regulators. So there's 2 dial regulators that we use. We have the range A, which goes from 0.02 to 3 liters of sweep, and then range E, 0.01 to 1 liter of sweep. The pros of it is that it's really accurate. You can see all the different dials that you can use, and it was something new and different that we haven't used before. We got away from that traditional ball regulator. The cons of it, it's a higher cost. So it wasn't something that was just easily accessible. We had to order it in, sort of get the approval, go through biomed, get it all cleared and checked out. There's a learning curve and that requires training. So there's perfusionists, there's ECMO specialists, there's doctors, there's everybody that's looking at the ECMO circuit. So it kind of just took a little bit more training to get everybody up to speed and involved in it. So we implemented it, like I said, into ECMO first, and we put the 2 dial regulators in tandem, and you can see on the right how it's put in. And this just allowed for, like I said, that more accurate flow. We have a connector at the bottom where the O2 line goes in, and it allowed for easier sighing. So we found we kind of got away from the quadroc oxygenator, and with the newer oxygenators that we're using, they're requiring more sighing. So we sigh our oxygenators every hour. We give it a really good sigh. So we now just move the O2 line from that connector over to the adult side and just move it up to about 3 liters of sweep, give it a good sweep on those neonates, and then we put it back. That made it also more consistent because you're not moving your dial regulator. The only thing you're doing is moving it over, keeping your hand on that knob, and then moving it back. So again, the inconsistencies aren't there just because you're never actually moving that dial regulator unless you're changing the sweep. We found that it was very consistent and reproducible. Everybody on the team liked it. No one really had any complaints. And I think that's says something because somebody always has something to say. So it was pretty good. This is just our sweep gas change calculation. So we normally look for a PCO2, what the doctors want. So it's somewhere around 40, 45 typically for our ECMO. So that's just what we use to get those precise sweeps. So then we move to bypass, and we just use 1 regulator, and that's in conjunction with the max blend. And we still do bleed in CO2 during our bypass cases for those neonates and the hypothermic ones. Again, we found very good positive feedback. We had more accurate values when we used the Connect. So when we print out our little report card at the end of the case to tell us how we did, our percentages were higher in that PCO2 range. So here is just the graph to show when we started using microblenders, which was in 2022. So you can see that there's a jump. Now, the numbers weren't bad from 2019 into 2022, but it just shows that they've progressively got better and that we're more compliant with our lab values and adding in that blender. 2024 is not over yet, so we're looking pretty good so far. So hopefully it just keeps growing. So in conclusion, we decided that we're going to keep our dial regulators. They're very consistent. They're safe and they're simple. There's no need to blend in that extra CO2, especially on ECMO. It's very reliable and it's easy. And on the bypass side of things, it's very, we're staying within our compliance, and we're all happy when we have better grades on our report card. So that's all I have for you. So thank you for listening.
Thank you so much, Amber, for a wonderful presentation. Amber actually has another presentation across the hall in the adult abstract session. So we're going to take her questions now. The following speakers will have we'll take questions at the end. Does anyone have any questions for Amber at this time?
Thanks for that talk, Amber. And it was nice meeting you yesterday.
Yes.
So I see that you use LevoNova products. What are your thoughts on their electronic gas blender for bypass?
I have only ever used it when I was a student on the electronic gas blender, and there was a lot going on when I used it as a student. So learning curve definitely, but it's doable. But I have not used it in the correlation to bleeding in the CO2 and the extra aspects on it. So I can't completely speak on it.
And do you use a CDI?
Yes.
All right, thank you.
Thank you.
Hey, Amber, great presentation. Thanks for that. Mark Niskowski, Children's National. What kind of oxygenators are you using in ECMO that you're signing the oxygenator?
We're using the Euroset. So we find that we're really sighing for the pediatric side, and then we use the Nautilus for our bigger patients, but that Euroset definitely requires a good sigh. Honestly, if we get a patient gas and it doesn't look that great, once we sigh it, wait a little bit and then get another gas, that typically is what was needed to be done. So, and a lot of condensation does come out of the port, so it's definitely needed.
Any other questions for Amber? Thank you so much.
Thank you.
I realize we did not introduce our moderators. First, we have Mark.
Mark Niskowski, Children's National, Washington, D.C.
And I'm Daphne Cannula from MUSC Children's Hospital. Our next speaker is Madeline Loftin. She is a perfusionist at Texas Children's for Pediatric and Congenital Heart Disease at Dell Children's Medical Center in Texas.
Good morning, everyone. I'm Madeline with Dell Children's. And just to introduce the project, this is actually something of an offshoot of a QA project that we had separately. And in collecting that data, we were able to realize that we could create a pretty resourceful tool for us to use in the operating room. So I will be discussing arterial cannula selection for pediatric congenital heart surgery using patient-derived data. Maybe. Want to point? It's going through on here, but not. So as we all know, for every bypass case, we have to choose arterial and venous cannulas to hand off to the surgeons at the field to cannulate for a bypass. And as we also know, sometimes that cannula selection process can be something of a contentious conversation with the surgeon when we don't all agree on the adequate cannula size. But essentially, in order to choose an arterial cannula, we take two important things into consideration, which are size of the patient and estimated flow, or the anticipated full flow that we expect to reach while on bypass. And it's important for every institution to have a standard protocol for what they accept their standard pressure drop to be. Over at Dell, our standard is 100 to 150 millimeters of mercury. And the literature actually states that at line pressures above 150 millimeters of mercury, you start to observe shear stresses and subsequent hemolysis. So it's important to have a standard practice. So to make that cannula selection, current practices would indicate referencing pressure versus flow graphs provided by the manufacturers of those cannulas. However, two important things that those graphs do not include are hematocrit of the blood, as well as the temperature of the blood that we are flowing through those cannulas. This lack of information is in turn misleading. And the reason why is because those reference materials are not exactly compatible with the clinical environments. The testing processes are done in vitro conditions, so in water, which has no viscosity, and at normal thermic temperature, so not, again, conducive to where we're practicing. So for our study, we use the Medtronic DLP-1 size cannula in sizes 8 to 16 French. Also, I believe this is the wrong presentation. This is an outdated presentation. I think that was pulled up. Sorry for the interruption. Sorry. So to continue, so for our study, we pulled full bypass records dating from 2019 to 2023. It was a little under 900 patients. And for every single bypass record, we recorded the average arterial line pressure as well as average arterial pump flow for every single case. And from here, we were able to create our own pressure versus flow graphs that demonstrate our historical data from every full clinical case. And then from there, we were able to further filter the data to include +or-1 standard deviation. So here's the interesting part, which is the visual tool that we are able to create. So, sorry, skipped one. So this is just to briefly overview our entire patient population. Again, it was a little under 900 patients. And just to point out, you can see from our largest cannula size to our smallest cannula size, those average hematocrit and temperatures that we were operating under, far from a 0% hematocrit and a 36 temperature. So here is the complete graphical display of each cannula size from the data we were able to collect. As you can see, there is an average trend line just to further delineate the data from each data set where that's kind of a close call, as you can see, between the 8 and 10 cannulas and the 12 and 14. And there's vertical bars, it's a little bit hard to see, that are just able to demonstrate an overlap in flow for those close call cannulas that we have. It helps us to visually differentiate between them. So this is that same graph, obviously on a different scale of our data. And what I am going to pull up are actually the manufacturer's graphs that are provided to us to reference. And you'll be able to see the substantial gap in the average pressures at the exact same flow. So there's a considerable difference between what we are observing in the operating room in full cases as compared to the reference graphs provided by the manufacturers. So it was really interesting to observe just how big the difference was. And if I could just zoom in on a specific example, these are the trends for just the 8-DLP. Our data is above and the reference material is below. And just as a reminder of those differences in average hematocrit and temperature in our clinical environment versus what those in vitro conditions are. And if I can just point out specifically, at about 600 cc's per minute of flow, our data suggests about a 210 millimeter of mercury line pressure, while the reference graph suggests about 70, which is actually a 90% difference in line pressure in what is suggested or expected between historical data and what the manufacturers suggest. So the creation of a patient-derived and all-encompassing graph to use in the operating room is a really resourceful tool for us, and other institutions should you so desire to create something similar to better select appropriate cannulas that follow best cardiopulmonary bypass practices for congenital heart surgery. And our future work is actually developing a formula or a code that will predict average line pressure based on parameters input by the perfusionist pre-bypass, just to get a better idea overall. Thank you.
Thank you so much, Madeline. Next, we have Sagar Jani. He is a clinical research specialist at the Texas Center for Pediatric and Congenital Heart Disease at Dell Children's Medical Center.
Thank you so much, moderators, for that introduction. I would like to start by thanking MSEC for providing the opportunity to display my work. Today, I will speak about the fate of vessels, management of cannulated vessels, following cervical extracorporeal membrane oxygenation. I have no conflict of interest to disclose. The efficient management of patients on extracorporeal membrane oxygenation, that is ECMO, remains a critical aspect of modern critical care medicine. ECMO has revolutionized the management of severe cardiac and respiratory failure, offering a lifeline to patients with limited treatment options. However, the optimum management of vessels during decannulation from peripheral cervical ECMO remains unclear. The traditional practice of vessel ligation and the more recent approach of vessel reconstruction have not been comprehensively compared in terms of patient outcomes. Hence, this study reports on the neck vessel management and outcomes after ECMO decannulation. After getting approval from the Institutional Review Board of UT Austin, the data was extracted from medical charts of all patients who underwent cervical ECMO cannulation and survived to discharge between 1st June 2010 and 30th June 2023 at Dell Children's Medical Center in Austin. Patients with central or femoral cannulation, multiple ECMO runs, or mortality prior to discharge were excluded from the analysis. Patency of the common carotid artery and the internal jugular vein were observed at discharge and at 1-year follow-up mark. Descriptive statistics were utilized to evaluate the vessel management and outcomes after ECMO decannulation. A total of 66 patients were identified that met our inclusionary criteria. Of this, 56% were female, 67% were Caucasian. The median age at initiation, ECMO initiation was 69 days. 50% were supported on VA ECMO at decannulation. This table here describes the management of the common carotid artery at the time of ECMO decannulation for patients that were on VA ECMO. 33 patients were on VA ECMO at the time of decannulation. The median days of ECMO support for these patients were 6 days. The cannula size in these patients ranged from 8 French to more than 15 French, with most patients receiving 10 French cannula. The artery was documented as ligated in 39% of these patients, reconstructed in 33% of these patients, whereas cannula was removed and pressure applied on 27% of these patients. Similarly, this table here describes the management of internal jugular vein at the time of decannulation for patients on both VV ECMO and VA ECMO. 66 patients had their internal jugular vein managed at the time of decannulation. The median days of ECMO support for these patients were 6 days. The cannula size in these patients ranged from 8 French to more than 15 French, with most patients receiving more than 15 French cannula. The vein was documented as ligated in 30% of these patients, reconstructed in 14% of these patients, whereas cannula was removed and pressure applied on almost 50% of these patients. Here we report on stroke as an outcome by the management of vessels. For the common carotid artery, the highest rate of stroke was observed in those who had their vessel reconstructed. For the internal jugular vein, the highest rate of stroke was observed in those who had cannula removed and pressure applied on the vein. However, neither of these were statistically significant. I would also like to point here that although the imaging used to extract the data was after the time of decannulation, there are chances that stroke might have occurred while the patient was still on ECMO support. Here, we report on surgeons' approach on management of vessels at the time of decannulation. I would also like to point here that the cardiac patient populations had significantly changed after the opening of Texas Center for Pediatric and Congenital Heart Disease at Dell Children's Medical Center in Austin. And we have changed our practices in the management of vessels at the time of decannulation. Here we report on the patency of the common carotid artery at discharge and 1-year follow-up mark. Of the 33 patients, discharge imaging was available for 7 patients. Of this 7, the artery was reconstructed in 6 patients, while cannula was removed and pressure applied in 1 patient. The discharge imaging showed patent arteries in all patients who had reconstruction, whereas 1 artery was reported as occluded in the patient with their cannula removed and pressure applied. Only 2 out of 33 patients had follow-up imaging for neck vessels around 1-year mark. Both these patients had their arteries reconstructed and were found to be patent at this time point. Similarly, here we report on the patency of the internal jugular vein at discharge and 1-year follow-up after decannulation. Of the 66 patients, discharge imaging for neck vessels was available for 12 patients. Of this 12, the vein was reconstructed in 5 patients while cannula was removed and pressure applied in 7 patients. The discharge imaging showed patent veins in all patients who had reconstruction, whereas 1 vein was reported as occluded in the patient with their cannula removed and pressure applied. Only 2 out of 66 patients had follow-up imaging for neck vessels around 1-year mark. 1 patient had their vein reconstructed while the cannula was removed and pressure applied in other. The imaging showed patent veins in both of these patients. The limitations of this study were being a retrospective study, the study may suffer from inherent biases such as selection bias and confounding variables which could affect the validity of the findings. The study included a relatively small sample size of only 66 patients, which limits the reliability of the results, especially for subgroup analysis or rare outcomes. While vessel patency was assessed, the study did not comprehensively evaluate clinical outcomes or assess the impact of vessel reconstruction on patient morbidity and mortality. Significant variability in ECMO decannulation vessel management and post-decannulation vessel management exists, which highlights the need for standardization and indicates a lack of standardized protocols in vessel management. The follow-up imaging demonstrates that a significant number of reconstructed vessels, both arteries and veins, remain patent. The utility of vessel reconstruction and its impact on clinical outcomes are still uncertain. However, the current study lays the foundation wherein the data suggests that vessel reconstruction can successfully preserve the patency of both arteries and the veins. However, future work with standardized imaging and neurological outcomes assessment is necessary to determine the optimal management strategy for patients undergoing decannulation from cervical ECMO. If you have any follow-up questions after Q&A, please reach out to me. I would also like to take this opportunity to thank Dr. Vanados, the senior author on the study, and Dr. Well and my co-authors, along with the Texas Center for Pediatric and Congenital Heart Disease at Dell Children's for supporting this project.
Thank you so much, Sagar. At this time, we're going to be taking questions for both Madeline and Sagar. They come up here, or I can bring the mic to you.
Thanks, guys, for some great presentations. My question is for you, Madeline, and I'm Greg from Boston Children's Hospital. I think your work is very important. 25 years ago or more, I did a similar thing before electronic records, and collected data and came up with flow charts for arterial cannulas and venous cannulas. I was looking at your data, which I think is excellent, but I think that the 90% off number is there for a reason. I'd love to look at that slide again if we could. So in your presentation, you mentioned that the system pressure, the average system pressure that you had on your y-axis was almost double what the manufacturer stated. And I think the reason for that is that you were measuring system pressure, and the manufacturer guidelines measure pressure loss. So do you have a comment about that?
Sorry, and could you repeat what you were mentioning about the scale? I'm trying to maybe pull
Yeah.
up the actual slide, but.
So I was a little surprised at the data because your graph was almost double the manufacturer number, which is very surprising. And I think the reason is that the y-axis that you were using was looking at system pressure. Is that correct?
So the line pressures that we recorded were the pressure drops across the cannula that we observe on the bypass machine. So on our, not necessarily our EMR, but on the system, the bypass system, we can just view the arterial line pressure, so we can track it throughout the case. And that was where we were recording it from. And on the graphs that has both of them, if I can ever pull it up,
That's it.
are on the same, it's on the same scale. So the scale of the data that we were collecting and what the reference graphs provide are on the same y-axis, if I'm answering your question correctly.
So I think that, so when you get the data from the pump records for several years, okay, so what is the x-axis here?
The average flow, so cc's per minute, and then the y-axis is average pressure, millimeters of mercury.
Right, and the y-axis, how is the system pressure? Does that say average pressure?
Yes.
And what pressure is that?
At that, so the one I pointed out was specifically for 600 cc's per minute. And according to the average trend line, or the average of the data at 600 cc's per minute, our data suggests an average line pressure of 210.
All right, so you said that's the average line pressure.
Yes,
So
sir.
if you go on bypass, your line pressure reads 200, it would show up as 200 on this graph.
Yes, sir.
I think what the manufacturer does is that they don't use the system pressure for the y-axis. They use pressure loss.
From what I could gather, and again, I'm not completely versed in their entire engineering testing process. From what I could collect is that they do create a kind of a loop, and they have a pressure transducer on one end and another one on the other, and they're measuring the pressure drop across the cannula within the loop that they're testing within. So you could very well be correct from what I understood and how I chose to compare the data. It is the pressure drop across the cannula at the same place.
Yeah, so if you took your data, which again, your data is very important
Mhm.
because it's still important, even if it's a little too high. But if you subtract 100, which is typically what a manufacturer does, that's a very common pressure loss value through a cannula. If you just subtract 100 from that and overlay that to the manufacturer data, it'd be reasonably close, but then it would take into account the hematocrit temperature that you mentioned.
Yeah. Thank you. No, very good question.
Any other questions?
Great presentations. Vince Olszewski, Louisville, Kentucky. Just a quick question for you, Madeline. Did you happen to exclude patients where you were doing low flow since you were using average flows and
did.
average pressure?
Yes. So actually another project that again stemmed from this project was really identifying where the outliers were laying within the data. As I mentioned before, each average trend line was filtered to include only +or-1 standard deviation from the mean of the entire data set for each cannula. And we were finding that a lot of the outliers were, we were at 18 degrees, the hematocrit was 42, or if we had 2 arterial cannulas, or lots of periods of low flow for ACP or CircRest cases. So within the data I presented, those outliers are filtered out.
Okay, thank you.
And Madeline, for the Medtronic cannulas that you were investigating and creating the flow study, what are you doing when the manufacturer doesn't have the cannulas available? What cannulas are you using in its replacement? And have you started to build algorithm off of that as well?
Actually, in light of the recent cannula shortages, we got in the Biomedicus cannulas. We maybe luckily haven't had to use any of the substitutes so far. We only use the Medtronic DLP, so there wasn't really space to try out other cannulas to investigate that. And in my literature search, I really couldn't find another study that duplicated with the data we were able to collect for the same cannula or in a clinical environment. It was all in vitro testing conditions. And this one study I did find that was kind of close, which was still in vitro, not OR data. We're using the Biomedicus, and the trends were kind of similar.
Thank you. We have a question from our online audience for Sagar. Has there been a retrospective study that follows children who've made it into adulthood to see if those carotid arteries were ligated and if there was a higher risk of stroke living with only one carotid artery?
So our initial literature review that we did a few months ago, we were not able to find few, but that's our ultimate goal, to build up on this research work that we have done so far and go back and ask the patients on their neurodevelopmental outcomes and neurological outcomes on what their life is after the arteries or veins were ligated and reconstructed.
I think that's a really wonderful area of research. We need to find out more. So we saw that there was a lot of imaging, or there were only 2 patients in each group that had imaging after 1 year. Is a new goal at your institution to start doing imaging on all patients?
Yes. So that's why I pointed out to the fact that there is a need for a standardized protocols and not only protocols for how to reconstruct or manage the vessels at the time of decannulation, but at the same time, the protocols should be designed in a way where we do imaging. So going forward, our institutions have changed our practices and we are planning to do that.
Wonderful. And one last question for Madeline. Has your data helped you convince your surgeons to maybe step up cannula sizes on certain patients or when needed or when the perfusionist thinks it's necessary?
More often than not, our surgeons would love if we gave them smaller cannulas. However, after showing them this, they're pretty convinced. And actually, it was one of our surgeons' suggestions for a particularly difficult patient. He wanted to know, well, what have I used in the past? And we kind of just had one data point to reference, and he said, no, what have I used before for every patient of this size ever? And so now that we've been able to show him exactly what he's used, it has helped kind of streamline that conversation. And I think they have a little bit more faith in that we know exactly where we're going to land for this cannula size for this patient and flow. So it has been very helpful for us to kind of make that process more efficient. So yes.
One last question for Sagar. For your protocol that you're talking about or standardization, your surgical team are the same surgeons doing all your ECMO cannulations?
Most of the times, yes. And in my final thank you, when I thank Dr. Bernardo, he is one of the surgeons at the TCP CHD, and this was his brainchild on we should follow these patients because currently there are not many publications or literature out there on this type of study. So his main focus is on we need to reconstruct the vessels more. So surgeons are on board with that.
Are there any other questions for Madeline or Sagar? Thank you both. Unfortunately, Saba wasn't able to register and is not here to present perfusion key performance indicators, monitoring and enhancing cardiovascular perfusion processes. So for, I guess, the next 10 minutes or so, I was thinking maybe we could talk about that amongst ourselves as an open forum for a discussion on enhancing our practices. I guess I can start. At Children's National, we have used the Viper Spectrum data collection system with the S5 pump for the EMR spits out a PDF. So for about 3 years, we have had this system and it's been collecting data. After our meeting that some of the perfusionists had in Cincinnati, Jim Rieger shared that he had built a compliance report that actually spits out a report card for every perfusionist at the close of case. So that has been, we just started it 2 weeks ago. We're still trying to understand what the numbers mean, but kind of trying to get your team to build practices that are kind of consistent. I would like to know if anyone else has started or building processes at their institution that they'd be willing to share. That'd be great.
I think this is an opportunity for a plug for the PD Perform Learning Network. Jim will be giving a talk, I believe, on Sunday, but this does a lot for you, especially if you don't have the ability for something like Viper, in that we're putting a lot of data in there, and there's a lot of very simple comparisons that you can do within your own center. Not only can you compare your center to other centers that are reporting to the registry, but you can certainly compare variances in surgical practice, variances in the perfusionist practice, all with a few simple clicks. I mean, there's dashboards that are already set up. There's not a lot of work to do. You can do it based on a time frame if you want to look at the previous 3 years and then narrow it down to the last 6 months because you made a change. Actually, very simple thing to do. It's a very valuable tool. I encourage everybody to get involved with it. It's a great opportunity.
Daphne Cannella, MUSC. So we are currently still paper charting. We have only been asking for about 20 years for EMR, but I see the light at the end of the tunnel. I think it's coming. But for right now, we're limited by manually inputting our data. And I'm sure like everyone, overworked, understaffed, there's only so much we can do. And so we are currently putting it in manually in a computer, and we are tracking certain things. And I'm curious, if you had to nail down 5 indicators of adequate perfusion, our list could go on and on and on and on, but what would you think would be the 5 most important things that could eventually lead to PD Perform? Because manually entering the data right now is what we'd have to do. if we don't get our EMR in the next year or two, our goal is to get PD perform and just manually do it with the super user in all her free time. And how can we prepare for this manual entry that seems inevitable? You know? What do you guys think?
Sure, put it back on me. Well, I can tell you, I've tracked data at every center that I've been at long before PD Perform was there and long before we had electronic perfusion records. So we actually have kind of a QA sheet, a calc sheet that we would record a lot of this data during the procedure. That way you had the information in one spot as opposed to having to go back to a record and try to find it. Plus it kind of standardized it for everybody else. I think it's difficult to specify exactly what it is you want to track. Like one of the things I started in Louisville when I got there was they demanded I had to do a quarterly perfusion quality report, and I picked the parameters that I wanted. So what do you pick? So I picked lactate as one of those for the first pre-initiation of bypass, and then the last on bypass, and then post-protamine, just as a comparison, using that as an indicator of quality of perfusion, if you will. But I had no idea what numbers I was picking, and I was looking for normal and said greater than 90% of the time. And I had nothing to compare it to. And as I presented it, I to the Heart Institute, I said, I don't know what these numbers mean because I can't find any data out there that anybody's actually sharing. So that's one of those tools actually right now that in PD Perform, we measure all those points in lactate. We do the same with hematocrit. We actually use that as a tool to help us build a team approach to management of blood products in the OR. With the goal being, everybody always says, well, we're not trying to do bloodless. And my point was, I'm just trying to reduce the amount of exposure of blood products. We can actually give you whatever hematocrit you want and use less blood products. And that's still a good thing. So that was one of the things that we looked at. It really helped us with driving anesthesia to pay attention to the volumes that they were giving before going on to bypass. And then more importantly, what we were doing when we came off bypass, because we were targeting higher hematocrits, say greater than 40, because then anesthesia starts shoving in products as soon as we come off, and they're dropping the hematocrit to 20. So to have some of those data points, and it wasn't specifically perfusion because we thought we standardized that practice, and we really look at comparisons between the perfusionists. Our goal is to standardize what our practice is amongst the three of us. Because then if you're doing anything relative to quality, there should be no reason that a surgeon asks for a particular perfusionist, because you should be getting the same perfusion each and every time. So a lot of the work that we did was centered around standardizing our practice and how we all did it so that we were doing it the same way every time.
That's a really good point. That's a really good point. We made the mistake similar. We had, not mistake, but we were trying to do annual reports, and it was tied to like our raises. So initially we're trying to pick a parameter that we need to improve, that definitely needed improvement, but wasn't going to, take away from our raises or something like that. So it was a really tricky position to be in. And standardizing across, we have a group of 4, was another goal within that too. So we ended up choosing something like calciums coming off bypass, something that needed to be improved, but was a tangible thing that we could consciously do and see results. And I think it's time to choose something a little bit stronger.
So when I started there, I was the only dedicated pediatric perfusionist, and I had 4 adult perfusionists that also did peds as well. So actually one of the things that I used as a QA parameter was neosynephrine use in the first 5 minutes of cardiopulmonary bypass as a means of, for me, was trying to get them to stop doing it every time, but to let them know how we were doing it. In the practice in the adult world, at least from what I was observing, was that they give a lot of neosynephrine when they go in, which we use that as an indicator of quality of initiation of cardiopulmonary bypass. The target being less than 10% of the time should we be giving it. And we had people that were at 75% of the time, and really within 6 months, we had that down to everybody was at least under 20%. So simple little things like that you can do, but just observations of, again, trying to standardize practice.
That's perfect. Sound like we were on the same page. Anyone else have any questions or comments?
Out of that, those conversations, I appreciate it. Thank you for sharing, Vince. Have you gotten anesthesia or the surgeons as in helping create a report for them as well? Our anesthesia team is actually, I give Andrew Waberski, our chief cardiac anesthesiologist, is trying to create standards and guidelines for them, which I give them all the credit for doing that, because that's the biggest hurdle is our anesthesia department and fluid after bypass, things like that. But from a data collection, how have you built a system for them or to follow up on blood utilization or blood products after we come off bypass? Of all the job that we've done on that system, how have you incorporated, or how would you recommend incorporating anesthesia's practice? Because they don't really want to have a report card for themselves. So how would you recommend we go about implementing that if you have already done so?
Sorry, I'm sure other people in here have opinions as well. One of the things that we did in that process was we tracked anesthesiologists. In fact, PD Perform, with the new update that should have occurred, but will be hopefully occurring in the next couple of months, we incorporated anesthesiologist into the registry data. We had surgeon, we had perfusionist. Now we will have anesthesiologist in there as well, which is really nice because we can back populate the anesthesiologist. So then when we go to our dashboard of blood product usage, and when we track blood product usage, it's what's in the prime, what we give on bypass, and what's given off of bypass, which includes pre and post bypass. So we have all the blood product usage in the OR. And I think that you can use that. The way I've used it was we would present this data to the quality meeting, which everybody in the Heart Institute attends, including the anesthesiologist. And we just did it as de-identified for both the perfusionists as well as we could do it for anesthesia. Once you bring it to their attention and people are seeing what you're accomplishing, we were able to reduce our blood product usage on patients from 0 to 10 kilos by 80% in a year's time by modifying the circuit, by modifying our practice, by having a unit of red cells split in the blood bank before it comes to the OR on all patients less than 15 kilos. So now I'm not necessarily using a whole unit. And then that split can go with the patient to the ICU. So if they need blood in the ICU, they're tapping into the same unit. So at least we're dropping donor exposure. So it's very simple to do. Once they start seeing it, they might not want to do it. But once they start seeing it, it almost becomes a competition thing. Just like when the perfusionists are looking at themselves compared to somebody else, then you drive this friendly little competition sort of thing that you have going on. But it makes them stop and look at it. We're fighting with the same issues, trying to standardize the anesthesia practice. We've been having a meeting with the surgeon, perfusion, and anesthesia to talk about some of these issues. Our current goal is to have a standard approach by anesthesia to management of the patient's fluid and blood products after bypass, because that's our most challenging time period. The variation amongst the anesthesiologists, it just amazes me that a new anesthesiologist comes into a center and they spend one day in the OR with one of the people that work there, and then the next day they're working on their own. And it's like, but they don't know what our practice is. I mean, I would never do that with a perfusionist and say, well, there you go, have a good day, I'll see you tomorrow. And I think that's the big thing that we need to do in what's going on. Anesthesia is very resistant to that. In fact, there was a speaker from, I think it was Boston Children's, that was at the meeting last year, an anesthesiologist that had discussed this exact issue. And somebody asked her the question about standardizing of her practice, and she just laughed at all of us and said, yeah, have you ever tried to tell an anesthesiologist how to do something? But I think that's a big challenge for all programs going forward in the future. I think everything needs to be done the same way every time, because how do you really compare your results unless you do that?
Greg Maddy, Boston Children's. So Daphne's question earlier, her first question to Vince was quality metrics. And when I think about perfusion and quality, I think about just the basics. And the standards and guidelines for pediatrics include cerebral nears, right? So I think we all should be including cerebral nears. And I know for a fact we don't all do that. So I think delta nears on bypass or something like that would be something to look at. The other thing, very, very basic, is temperature management. You know, how often are your team members going above 37 degrees on the arterial? And how many people are still using a 10-degree gradient, right? It couldn't be more simple. It's not as sexy as DO2, area under the curve, all this stuff, right? We don't know what that data is going to show yet in terms of long-term outcomes. We know a little bit about the AKI stuff, but I think those are quality metrics that every center should be looking at. And I'll tell you that many years ago, we looked at temperature management on our team. And, you know, Vince was saying it's a competition, but sometimes you got to show your team, and even in an anonymized way. I have 14 people, 14 perfusionists on my team right now. And you can look at that data. You don't have to shame people, but you can just look at it in an anonymized way. And what we were seeing was that there were some people on the team that were going above 37 degrees in the arterial line 80 to 90% of the time. And there were some people doing it 0% of the time. And we shared this data with the surgeons. We talked about it at our quarterly conference, perfusion conference, with the surgeons and anesthesiologists. And eventually we got that down to 100% of people not going above 37 or 0% going above 37. So that's a simple thing. And I think that matters because we know from the literature that hyperthermia for the brain is not good. So that, I mean, that's a simple thing. It's not sexy, like I said before, but that's a simple thing. We should not be going above 37. And it is part of the standards and guidelines. It references at least the 2015 paper about watching your, well, it's adult literature, but limiting your temperature gradient and not going above 37.
Thank you so much for that comment. I appreciate everyone being here and for a really great session. And thank you for our speakers. I think we're going to conclude about 5 minutes early. Please take a break and then go to the exhibition hall for our next for the exhibition. Our next pediatric session is actually from 10 to 11. To clot or not to clot, this is the session. We'll see you then. Bye-bye.